Good morning, Kathy. We are ready.
Good morning, everyone. Thank you for calling into our GHA Patient Safety Award-winning Power Hour. I am very excited to have Emory University here with us today. We have Melissa Bujumdar and Elizabeth Heckenbleichner, and both of them are going to be talking about their award-winning project, Improving Venous Thromboembolism Prophylaxis Compliance Among Bariatric Surgery Patients. And Melissa is a registered dietitian and bariatric coordinator at University Hospital Midtown. She acts as a national media spokesperson for the Academy of Nutrition and Dietetics and is nominating chair-elect for the Academy of Nutrition's Weight Management Dietetic Practice Group and participates in the American Society for Metabolic and Bariatric Surgery Program Planning Committee. Melissa speaks at national conferences on topics related to obesity and bariatric surgery, quality improvement, and working with the media. She is co-editor of the third edition of the Academy of Nutrition and Dietetics Pocket Guide to Bariatric Surgery and is a certified specialist in obesity and weight management. She loves quality improvement because of the crosswalks of collaborating with others and analyzing data. Love the analyzing data. Can't go without data. So welcome, Melissa. We're so excited to have you with us. And Elizabeth is a general and bariatric surgeon who specializes in advanced minimally invasive GI surgery at the University Hospital Midtown. She's actively involved in multiple research and quality improvement projects for metabolic and bariatric surgery patients. Elizabeth is the principal investigator of a randomized controlled trial evaluating outcomes using endoscopic versus suction calibration system techniques for performing sleeve gastrectomy. Her quality improvement projects have involved robotic emergency undocking simulation drills, the impact of inpatient pharmacists on discharge medication reconciliation processes, as well as implementation of standard perioperative enhanced recovery tools. And Elizabeth is a member of the publication and resident fellow training committee of the Society of American Gastrointestinal and Endoscopic Surgeons. And she serves as an abstract reviewer and is a preferred peer reviewer for Surgery for Obesity and Related Diseases editorial board. She is also very passionate about the quality improvement work due to its hands-on, data-driven, multidisciplinary approach to solving problems and improving the safety and efficiency of surgical care. So we are so excited to have both of these highly regarded professionals with us today to share their journey and tell their story. So I am going to turn it over to you, Melissa. Take it away. Thank you so much.
Thanks for that great introduction, Kathy. We're going to have Dr. Elizabeth Heckenbleichner start us off today, and then we'll trade off towards the end.
Thank you, Kathy, and thank you for pronouncing my last name correctly. That doesn't happen very often. But on behalf of myself and Melissa, we definitely want to thank the Georgia Hospital Association for the privilege to discuss some of the work that we have been doing around venous thromboembolism or VTE chemoprophylaxis. And we are certainly both very passionate about the work that we do in this area and hope that by sharing our journey, this can help other institutions who are embarking on similar initiatives. We have no financial disclosures, and I certainly would be remiss if I didn't highlight and thank the core team of individuals that you see here on this slide. They have been supporting us and helping us execute our VTE work from day one. This is a great multidisciplinary group. Some of our team members here are on the front lines, particularly in the preoperative holding area, which encompasses 2 units on separate floors, as well as our nursing leads on the post-operative unit, where over 90% of our bariatric patients stay after their index operations. We have other team members that are more behind the roles, behind the scenes and data analyst roles, as well as sponsorship from higher level admin and leadership positions. So this is probably not going to come as a surprise to people here in the audience, but metabolic and bariatric surgery patients, or MBS patients, have many risk factors for developing postoperative VTE events. These events include typically deep vein thromboses or DVTs that happen in the extremities, or in the lungs, a pulmonary embolism or PE event. Some of the important independent patient-related risk factors include age, body mass index or BMI, gender, a prior history of a VTE event, alcohol abuse, congestive heart failure, as well as immobility and lack of walking that can sometimes happen in the postoperative period. Some of the important procedure-related risk factors to highlight include open surgery, increased operative time greater than 3 hours, and postoperative complications. So in our institution, we've always looked really good on paper. Historically, we have always had very low VTE events in the postoperative period. Our rates have been well under 0.5%, which is consistent with national benchmarks. But we had 2 sentinel VTE events that happened across 2019. And sadly, one of these events was associated with such significant complications that one of our patients passed away, and this was very hard for us. But this led us to really pull back the covers, so to speak, and then look into our process measures in this area. And when we started doing a deeper dive, we realized that among our practices that we had widely variable VTE prophylaxis prescribing among our surgeons, and overall we had low compliance rates for both preoperative and postoperative VTE administration. So we clearly had a problem and we needed to fix it. So why the big fuss about VTE events? We know that VTE rates are very low in the postoperative period for MBS patients, typically 0.3 to 0.4%. But the problem is this impact that it has on complications. We know that VTE events have a significant impact on perioperative morbidity and mortality. And when you look at mortality alone, it increases from about 0.1% to as high as 2.6% when a patient has a PE or DVT event in the postoperative period. Postoperative VTE has been the greatest risk association for postoperative readmission and mortality when you look at other complications. So simply put, this can be a life-ending event for our patients. And these are patients that are coming in for an elective operation, and it takes months and months of hard work and preparation to get there. So we need to do everything we can in our power to prevent VTE events from happening. So we know it's important to prevent VTE events, but what are the guidelines in this area and how do we make this happen? National organizations like the American Society for Metabolic and Bariatric Surgery, or ASMBS, endorse that MBS patients are moderate to high risk for VTE events and that chemoprophylaxis should be used, but there's no level 1 evidence to provide guidance regarding the type, dose, or duration of VTE prophylaxis agents in these patients. So due to these limitations, institutions like our own are left to develop our own protocols based on the best available evidence as well as local wisdom. And so as you can imagine, the natural result of this is a wide variety of protocols for VTE prophylaxis, both local regionally as well as nationally, because everything is being done in a decentralized fashion. So bringing this back to our own institution, I want to start by telling you guys a little bit more about Emory University Hospital Midtown, or as we call it, EUHM. This hospital is in the heart of Atlanta. For those of you that are familiar with Atlanta, we are surrounded by this outer belt or perimeter of 285, and we are literally in the middle of that in a pretty urban spot. Our hospital is a 500 to 600 bed hybrid institution that has community and academic physicians, providers, and staff. And our bariatric center at EUHM is one of the 3 MBS equipped designated centers in the Emory healthcare system. We have the largest surgical volume of bariatric cases, as well as just surgical volume in general across our system. And, with this being the case, our practices are important because we take care of a lot of wonderful patients. And we can have a big impact on the rest of the system. And as a healthcare system and institution, we want to have the best practices. This is a snapshot of what our core surgical team looks like. This team is spread across multiple campuses with surgeons at very different levels of training. During the predominant work for this VTE initiative that we've been doing, we had 7 Emory faculty surgeons. We now have 8, and this will likely expand to potentially 1 to 2 more. We do have 1 recently retired private practice surgeon that was actively involved in this work, and then 2 Morehouse faculty surgeons that are still present at EUHM. We also typically work with 2 minimally invasive surgery fellows on a weekly basis. They operate with us. And then we have multiple different general surgery trainees and residents that are with us and rotating on a monthly basis. So as you can imagine, there are a lot of moving parts here. And this can present a lot of educational challenges as you try to rally people around these initiatives. In addition to our big surgical team, this is our involved process for getting patients from the preoperative holding area to the operating room, and from there safely to the PACU and to the floor where they recover. This also has a lot of moving parts, different team members and steps where providers have to kind of jump in and do their part. So for our process, when our patients arrive to the preoperative holding area, our anesthesia colleagues typically write orders for anti-nausea medication, antibiotics, and non-narcotic pain medications. The surgical team, however, is responsible for writing preoperative heparin orders, which have to be given by the preoperative holding nurses prior to rolling back to the operating room. This ordering is typically done by the residents and sometimes the fellows. The surgery then starts after our call to order, at which time we hopefully address whether a patient has received VTE chemoprophylaxis doses. And then post-operatively, when patients get to the floor, the surgical team, which typically is the residents or fellows, put the orders in for post-operative VTE chemoprophylaxis. And then on the floor, of course, our nursing providers administer the VTE prophylaxis doses. In addition to all of this, all of our patients are written for the standard sequential compression devices or SCDs and are encouraged to ambulate at least a few times a day. So in our big hospital, amongst our busy surgical team and with our involved process that I've just outlined, this was our baseline data. These were our baseline conditions across 2019. This graph here is a run chart that shows our baseline compliance with preoperative VTE prophylaxis at the patient level. And as you can see, highlighted here in the red line, this was our median percentage compliance across 2019. And that was pretty low at 45%. This is certainly not standard of care, and this was data that we were really completely unaware of until we started this initiative. When one of our Sentinel events happened in the fall of 2019, and that was specifically in September of 2019, you can see that we were sort of at a low point for compliance at 22%. And again, this number really translates to only 22% of patients in that month receiving a preoperative dose of VTE prophylaxis before going back to the operating room. And it was really at this time frame in the fall, September, October of 2019, that we really started to look into our data and pursue efforts to improve compliance. This is another graph showing some of our additional baseline conditions. This is another run chart that demonstrates our percentage compliance with giving pre-op VTE prophylaxis within 60 minutes of anesthesia start time. Anesthesia start time is our closest surrogate to inducing a patient, putting them to sleep, and starting a surgery. Typically, this number should be less than 60 minutes. And as you can see here, with the red line hiding our median compliance, this was only around 40% overall for the year of 2019. And there's a lot of variability around this, with no numbers really across a monthly period consistently being above or below the mean, or excuse me, median. So not only were some of our patients not getting VTE prophylaxis, but sometimes we were literally giving this medication in the morning at 7:30, and then patients wouldn't have their surgery sometimes several hours later. So this was incorrect. It was infrequently given in the right time frame. And this last graph here for our baseline conditions shows different bar charts for the average total hours between the anesthesia start time and actually giving our first post-operative VTE dose. So for the months of September, October, and November of 2019, you can see that the rough average of this time frame was actually 18 hours between when a surgery was essentially starting and when people were getting their first postoperative VTE chemoprophylaxis dose. And when you take this data in the context of the 2 prior slides that I showed you, not only were we not giving patients preoperative VTE chemoprophylaxis for the majority of the time, we were also giving it incorrectly in terms of time frame. And then some patients weren't even getting post-op VTE doses until 24 hours after their surgery, with literally nothing on board beforehand. So as you can see, we clearly kind of had an uphill battle to overcome. Realizing where our baseline conditions were, Melissa and I sat down and we had a brainstorming session, and we did this fishbone or cause and effect diagram exercise, which you see here. These exercises are meant to help identify as many causes for a problem and sort them into useful categories. And after doing this, we realized we had a much more complex issue than originally understood. But it at least gave us a framework for moving forward for executing and targeting interventions for starting to tackle some of these issues. And our issues span multiple categories, including heparin shortages, which was a systems issue we were facing at the time of this initiative. We also had no tracking mechanism in place for looking at our data and sharing it with providers. We had inconsistency with who was placing the order, both preoperatively and postoperatively, that had to be addressed. We were not routinely addressing VTE chemoprophylaxis during our call to order or timeout, which happens in the OR right before a procedure begins. And finally, we realized that a lot of our patients were even refusing postoperative VTE doses on the floor. So embarking on this journey to improve VTE chemoprophylaxis, prescribing practices, and compliance in our MDS patients, we did set goals and targets for what we wanted to accomplish. And some of this is shown here. First and foremost, we wanted to create a standardized perioperative protocol for VTE chemoprophylaxis administration. If you can create a single protocol and align everyone around it, this becomes a much easier thing to measure. Equally as important, one of our main goals was to track and improve compliance in this standard protocol and create standardized ways of communicating, reporting, and sharing this data back to our team. Lastly, we also wanted to identify key barriers leading to protocol noncompliance and assess whether improved VTE prophylaxis compliance increased clinically significant bleeding events, which are typically those that require a postoperative transfusion and or reoperation. So we overall did set the bar pretty high for ourselves, and our goal was to increase our preoperative heparin administration from a baseline of 22%. That was actually the time frame in September of 2019. From previous slides, you'll note that our median was overall closer to 40%, but we wanted to increase this number to 90% by October of 2020 because we felt like this was a reasonable and important goal to hit. And we wanted to do this without increasing our bleeding rates. We also wanted to identify the top 3 barriers to VTE chemoprophylaxis administration in the postoperative period and reduce these errors by 20% also by the fall of 2020. So in the context of project goals and aims for quality improvement work, there are typically 3 main categories of measures that should be assessed to help understand the impact of the changes you're making. So the first is outcome measures, which is shown here on the left side of the screen. And for this particular work, our outcome measures were VTE events or DVT and PE rates. For our balance measures, this included, again, clinically significant bleeding events, which essentially for us was transfusion rates because we have not had to reoperate on any of our patients in the past few years for any type of a bleeding issue. And finally, for our process measures, which typically for this kind of work, you want to have 3 to 5 of these, we looked at several things, including compliance with preoperative and postoperative VTE administration, timing between giving preoperative dosing and anesthesia start time, as well as timing intervals between anesthesia start time and the first postoperative doses and then subsequent postoperative doses for VTE chemoprophylaxis. This data here just gives you a snapshot of our average EUHM MBS patient. This is particularly, for our study period and also very consistent with the patients that we just treat in general. This data encompasses about 300 patients from September of 2019 through December of 2020 and includes both primary and revisional surgery. So our average patient is a female. So this is typically 84% of our patients, usually in their mid 40s with an average BMI of around 46. We are a sleeve dominant institution, so about 72% of our volume is sleeve gastrectomies, and most of our cases are done laparoscopically. And about 30 to 40% of our patients have at least one of the classic obesity-related medical comorbidities, which include hypertension, hyperlipidemia, obstructive sleep apnea, and/or type 2 diabetes. And our patients are typically in-house with us for about 1 to 2 days post-operatively and are seen in the office or clinic setting several weeks after surgery. So moving along, I'll talk about assembling our team. I apologize if I jumped too quickly into the next slide, but really, in assembling this team in the fall of 2019, in addition to our core team that was previously shown, we did bring together stakeholders in a variety of areas to really help vet the literature, discuss local and regional practices, and really hone in on developing, deploying, and tracking our protocol. While patients were not directly involved in these discussions, they have been engaged in understanding the development of our VTE protocol, as well as just educated on the importance of mitigating VTE events in general. And as part of our MBS equip accreditation, we do meet quarterly with many of the individuals and stakeholders on this team and have been able to use these meetings and others as an opportunity to increase visibility for all of our work and efforts. Moving along here, I want to show you here just a snapshot of the timeline for our VTE quality improvement work. This is a snapshot of a lot of the foundational work that was done from the fall of 2019, which is shown on the left side of the screen to the right side of the screen, which sort of ends in the summer of 2020. After assembling our A team, we met to identify and understand. I apologize, I advanced the wrong slide here. We met to identify and understand our workflow and process for ordering VTE chemoprophylaxis. So this was roughly October to November of 2019. We developed the first iteration of our VTE chemoprophylaxis protocol by December of 2019. This was in the context of national heparin shortages at this time. In January of 2020, we started to collect data on the underlying reasons for protocol noncompliance through chart reviews and interviews with staff. And of course, we were doing all of this in the midst of the COVID-19 pandemic. And we did hit about a 2-month lull of bariatric surgical cases, but then resumed operating in May of 2020. And despite this gap, we did decide to forge ahead with another quality improvement initiative for our patients, which involves enhanced recovery protocol. And this has been intimately associated with our VTE work because we built a checklist that has line items across the perioperative period highlighting when patients need to receive VTE chemoprophylaxis. And I'll show you this in a couple of slides. But since the summer of 2020, after this period of foundational work and successful results, which we will discuss in a few more slides, we have continued to work as a team in the Gemba. This is a Japanese term meaning the real place, in which in lean methodology is the place where the real work actually happens. So both Melissa and myself are continuously present. And we work in the context of Kaizen, which is another Japanese term meaning continuous improvement or change for the better. Here, this slide features the key changes in our VTE chemoprophylaxis protocol and the timeframes under which this happened. From the fall of 2019 to May of 2020, we have been giving heparin for our preoperative VTE dose within 60 minutes of anesthesia start time. And during this initial timeframe, this is when we had national heparin shortages, we had to use low molecular weight heparin in the postoperative setting every 12 hours. This did start on postoperative day 0. And this particular medication in the postoperative period was a point of contention for our surgeons due to the longer half-lives and more concern for bleeding risk. So it was hard to do convincing in this particular area of using this medication. But after May of 2020, as the shortages went away, we were able to streamline our protocol to using heparin only. So we are using heparin both in the preoperative period as well as postoperatively now. And in the postoperative setting, we give 5,000 units every 8 hours after surgery, starting on postoperative day 0 with our default times at 2 p.m., 10 p.m., and 6 a.m. And depending on the time of surgery, you may or may not be able to get an additional dose on postoperative day 0. We do have some systems challenges for how the heparin is ordered, such that if you order it within 4 hours of one of those default times, it automatically kicks it out to another dosing interval. And this is just a safety mechanism that we are still trying to sort of overcome in our institution. It can be overridden if you put the dosing correctly for the specific date and time, but sometimes doses get missed because of this. Moving along, as I previously mentioned, this is our global perioperative enhanced recovery protocol checklist. This is something we use for all of our MBS patients. This is a living document that gets updated and has had multiple iterations due to necessary changes that happened in our VTE protocol, for example, over time, as well as feedback from our team. It does not go into the patient medical record, but it does get collected by Melissa, and we use it for feedback and process improvement. And it, of course, serves as a nice guide and reminder to our nurses about giving VTE doses. So the first star here highlights a line item for when the preoperative dose is given in our protocol. The next star highlights a line item for when to address a VTE prophylaxis during the timeout or call to order in the operating room. The next star highlights when our first postoperative dose is given on postoperative day 0. And then the last star is an additional line item for the postoperative day 1 dose of heparin. In addition to our team, our standardized protocol and checklist, we, as you can imagine, have a lot of educating and engaging of our staff to do along the way. And this is certainly a huge part of any quality improvement work, and certainly our VTE initiative. From an education perspective, we've done in-services with preoperative holding staff as well as our postoperative unit. We have individual sessions with nursing providers. We attend huddles and other meetings to provide updates on our progress and give feedback. We do engage patients in interviews and get feedback from them and provide additional one-on-one education. We have also created a centralized educational resource guide for our surgical trainees so that as they rotate with us on a monthly basis and change all the time, they have at least the same document and materials to go back to reference our VTE protocol. And then we also send out emails to providers and staff when we need to inquire about non-compliance and just provide additional feedback and education as needed. This is another intervention that we did that Melissa actually developed and deployed herself. It was a one-page education sheet, initially designed for nursing staff on our postoperative unit. We did this because we do have a lot of travelers and providers who aren't as familiar with our patients in VTE chemoprophylaxis protocol. So this acts as sort of a centralized education sheet, not only about the importance of VTE prevention through ambulation, STDs, and chemoprophylaxis, but it allows us to have the nurses use it themselves, but also help interact with other nursing providers and use this as an education tool for patients. And we also use this document in our mandatory preoperative nutrition and education classes needed so that our patients are educated on the importance of these efforts preoperatively. Finally, I want to highlight the standardized reporting structure, processes, and venues that we have leveraged for educational purposes, as well as transparency about our successes and failures. Melissa sends out monthly emails with highlights of key areas of VTE non-compliance, as well as areas of success and areas for improvement. There's a snapshot of this email here on the top right corner of your screen, and you can see a little picture of Melissa up there. But this is what our email looks like. In this email, we share the same data and the same slide deck that gets continually updated so people are seeing the data over time, and more importantly, seeing it in a standardized fashion. And on the bottom right corner of the screen, you'll see one of the first slides in this slide deck that kind of gives an overview and outline all of the data being presented, data that's overall data, interval timing data, as well as data by surgeon level. And so you can click on these different highlighted links here to drill down into different sections in the slide deck as needed. So this has really helped us be consistent and transparent. And it really helps rally your culture around being both accountable and just. So in addition to these standardized reporting methods and data reporting, we actually share the same slide deck and outcomes at our bariatric monthly clinic team meetings. We report this data at the EUHM Quality Improvement OR Committee meetings, and then also our quarterly MBS equip meetings, in addition to other system quality and bariatric meetings. So without further ado, I will turn the rest of the presentation over to Melissa, and I'm happy to advance slides for you, Melissa, if that would help.
Yes, that'd be great. Thanks, Dr. Heckenbleckner. As Dr. Heckenbleckner mentioned, we are tag teaming in the Gemba, and we are tag teaming our presentation today. So all of our efforts, what did they result in? So we're first going to look at our process measures. So within our results, we'll start by reviewing exactly where we started from, right? We started looking at our data in early fall 2019, and you can see that when we created the protocol in December, we still didn't see that jump in compliance until February, when we started really drilling down on every single case, looking at exactly what the reasons for the misses, tracking it in real time, interviewing our team. And we really were able to get some information that was helpful in creating interventions by being in the Gemba and talking with our team members face to face. We used a Pareto chart, which we'll share in a few minutes, to identify the top reasons for the errors and then create those interventions specific to match the errors. And then we continued to track our compliance and report it out in that standardized fashion that Dr. Heckenbleckner mentioned. At multidisciplinary team meetings, we share the group data, and then through email, we also provide individual surgeon level data, which was something that was requested by the team. We're seeing the importance of our continued efforts because, as you can see from our March 2021, we did have a little bit of a drop. This 88% is actually just 2 misses, and one was from a newer surgeon who we need to update on the protocol, and then another one was actually given intra-op. So we want to view that as a good catch, but still not in accordance with the protocol, so some room for improvement. Kind of an interesting run chart at this point because our median has moved up to 100% because we have had 100% compliance 10 of the last 15 months, 12 of those with being over our 90% goal. So we feel like good success, but as many quality improvement initiatives are, the gains are harder to maintain. And so we feel to get continued compliance, we need to continue with interacting with our perioperative nursing and surgical teams. For example, just 2 weeks ago, we shared the misses that you see in March 2021 in huddles to create some additional awareness. Next slide. All right, so our results here are showing the most recent quarter with nearly 93% of our patients receiving preoperative heparin within 60 minutes of surgery, which was the mentioned goal that we're aiming for. That 93% actually breaks down to just 5 patients outside of that 60 minutes, one of which was only 4 minutes over, 2 others at 90 minutes, one given intra-op, as we mentioned, which was really a good catch, and then one not receiving it. So while we're absolutely achieving our goal here, you know, there is a little bit of room for improvement, but overall very close to what we set out with that 60 minutes that we're happy to see. Next slide. This graph shows the variance in when or if heparin was given preoperatively. Even after our protocol started, we still saw some variance, as you can see, until June, when the preoperative holding nurses developed a link between a standard practice and administration. So typically the OR circulator comes to the pre-op holding area, greets the patient, and this is generally very close to the time of surgery. So this helped couple the VTE prophylaxis directly with the readiness of the OR and the OR team, rather than as an independent task. And that's where you see that we had very consistent timing over the last 6 months. That checklist that Dr. Heckenbluthner mentioned has further reinforced the timing, and we match the order of the checklist items to the order of the workflow. So our frontline team was very engaged in the development of the checklist to create the items on there that they wanted to see and in the order that worked for them. Next slide. As you can see here, our blue bar has risen over time. That blue bar is demonstrating the patients who receive VTE prophylaxis coverage on post-op day 0 or within 24 hours of surgery. So looking back at September 2019, we still had some green bar, which is post-op day 1, and then red with not receiving it at all. And you can see over time, we have nearly no red bars, and the green bars too have really decreased as well. So we can say at this point that 100% of our patients are receiving VTE prophylaxis on post-op day 0, majority of them receiving 2 to 3 doses within that 24-hour time frame. Next slide. The timing between our pre-op administration and post-op dose continues to be our biggest area needing additional improvement, as we mentioned. There's a noticeable reduction in time still and consistency, but we would like to see this time closer to 8 hours, which is the traditional time that heparin is given Q8. So the problem lies with the 2 sources of institutional standardization that we are trying to overcome, one of which is the timing a +4 hour default time based on when the order is written. So for example, a first case start might start at 7:30. The case finishes at 10 o'clock. The orders are written by the surgical team, let's say 10:30. That defaults to the first time being 14:30, but that pops right over our default administration times, which is 1400. So that pops the patient receiving their first post-operative dose to 2200, which is about 15 hours after their initial preoperative dose. So the variance in the graph here is seen because obviously this graph is reflective of not just our first case starts. So we'd like to see this 12 hours closer to the 8, and we hope to do that with an updated order set. Next slide. Initially, our post-op agent that we chose because of the heparin shortage was Lovenox, or low molecular weight heparin. And then in June of 2020, we shifted that protocol to be heparin-centric, and therefore our goal, you can see the green line kind of shifted down. The goal with Lovenox was Q12, and then with heparin was Q8. So we now are receiving, the patients are receiving the timing between their dose 1 and dose 2 is close to the 8 hours, and that's where we'd like to see it. So again, as mentioned before, the room for improvement is more between our pre-op dose and post-op dose 1. We're feeling comfortable with the dose 1 and 2 differences. Next slide. Here we have an example of our surgeon level data. For a while, we were showing kind of an overall rolling percentage, but shifted to different timeframes to demonstrate the continued improvement from our baseline. So at this point, the majority of our surgeons are over that average of about 86%, with just our newest surgeon who has only 2 cases so far. One of those was the miss below that line. So we are feeling that this little healthy peer pressure was helpful in getting the whole team on board. And again, this was something that our surgeons actually requested. So they work very well on looking at individual data and overall data. And this model has worked well for other projects as well. Next slide. So here our Pareto chart is helpful in identifying which of our interventions we needed to target to make the most bang for our buck, if you will. So you can see, as we mentioned before, our order timing error continues to be our biggest room for improvement. And with our new order set in queue, we're hopeful that we can remove that +4 hour default. Before we made the decision to just remove the +4 hours, we actually sat down again as a interdisciplinary group and looked at each patient. If we had removed the +4 hours, when would that patient have received the VTE prophylaxis, and was the team comfortable with that time frame? So we are waiting for our electronic medical records to switch to a new system. So the queue for getting our new order set has been longer than typical, but we are next in line and hopeful that that helps things out. The patient refusal was not an error that we expected going into this project, but during our enhanced recovery protocol, as Dr. Heckenbluthner mentioned, we were able to identify that the nurse messaging was typically that if the patient was walking, if they were using their SCDs, then they didn't necessarily need the pharmacological administration. So we did work to help with a culture shift and walk through with the education that we mentioned, that we did want them to have all three of the SCDs, the VT prophylaxis, pharmacological prophylaxis, and ambulation. And at this point, the nursing team created their own escalation process of telling the surgical team if a patient refused it after the education was implemented. Pharmacy errors were also something that we didn't expect to see, but was actually just a simple fix. We had included our pharmacy core team that covers the unit where our bariatric surgery patients go in our decision-making process that failed to educate the entire team. So when there's cross coverage, we needed that education too. Next slide. We have been tracking our errors over time, and you can see that when we initiated the protocol, we saw some reductions, but then with the shift in protocol, which was May, June of 2020, we started to see that increase again, and that is the majority because of the order timing, which we were able to see from the Pareto. So we expect this to go down once we have our updated order set and to have less patients with an error. But like I said, most of these are just with timing and the patients are still covered, but something we hope to get a reduction in. Next slide. Our percent error rate is showing the number of errors over the number of potential errors. So the individual patient has potential for 1 pre-op error and 3 post-op errors of what we're tracking. And so again, this is decreased in 2020, and then the increase because of the order timing, majority of those with the post-op, and patients are still getting coverage, which is the main goal. Looking then, next slide, at our process measures, now we'll shift to our outcome and balance measures, and our balance measure being the transfusion rates. And you can actually see that our baseline, which was like the 2019 data, we had 3 transfusions, 3 patients that received transfusions. But now in 2020, 2021, we actually have had a reduction in that. So that was kind of our balance. Are we seeing more bleeds? And the answer is no. So we're happy to see that. Then, of course, with our outcomes, the idea was to reduce or eliminate DVTs and PEs. And we've had 1 PE in this time frame and was actually technically outside of the 30-day post-op range that we're looking at, but we wanted to be transparent in our results today. So we feel that our results, our positive outcomes in our balance or in our process measures have also resulted in positive outcomes with outcomes and balance measures. So for conclusions and next steps, we, as we've mentioned before, continue to have the challenge, as many of our institutions and hospitals do right now because of COVID, of rotating staff with travel nurses, high turnover rates and floats, as well as our continued surgical team rotating, which will not end even after COVID. So we just need to continue to be in the Gemba, and I think that our order set will continue to help as we approach our updated power plan. We've learned a lot about just the work to being in the Gemba, being with the frontline team, not only to really understand what's going on and to have our interventions match their workflows and their processes, but to gain that rapport. And so that we are elicit feedback from them and not telling everybody what to do. We feel that consistency has really helped us, consistency with our data, consistency with being present, and consistency with our chart reviews and data review. Next slide. So overall successes, we've obviously made improvement in pre and post-operative VT prophylaxis compliance, with our pre-intervention median of 44% now being at a post-intervention median of 100%. We saw that only 40% of our patients pre-intervention were receiving the heparin within 60 minutes. Now we have over 90% within that specified time. 100% of our patients are receiving VT prophylaxis on post-op day 0, many of which multiple doses. The standardization of our protocol and compliance reporting has helped us with other projects as well, and is helping our group in general be more data-centric and make data-centric decisions. We have transparency and errors and close to real-time feedback, which has helped provide a culture, a just culture and safety culture, and created open dialogue to identify best practices in other perioperative care. And we have increased academic productivity submitting this project not only to this venue, but for abstracts and a manuscript in queue. We hope to serve as a guide to other surgical specialties. Our perioperative team has used their lessons learned and workflow to create standard work for all surgical specialties around the administration of pre-op VTE prophylaxis and coupling it with that OR circulator coming to the pre-op holding area. And overall, our biggest win, we feel, is contributing towards an environment of process improvement, quality improvement, and a safe and just culture. For next steps, we do hope to use IT support to update our power plan as mentioned and remove defaults, both with timing, as well as to leverage technology. We feel that automatic alerts and real-time feedback could help make this process, which is heavily manual, with manual chart abstractions, manual interactions with the team, to more of default and automatic alerts. We would like to see mandatory VT order sets requiring an opt-out if the patient applies. We continue to share our efforts and elicit feedback across the Emory system with both bariatrics and other specialties, and hope to both learn from our teammates across the system and share our best practices. Our list of references, if interested in some more information on bariatric surgery and VTE prophylaxis, but we'd like to open things up to both feedback and questions if they're out there.
This was a great presentation. Thank you both so very, very much. I just had a couple of quick questions for you on the overall. You had some very good results and very impressive with doses 1 and 2. And I specifically loved the chart that you were showing the physician and the peer review and then kind of where your physicians were. And my question, I guess, was how difficult was that to get all the education for your staff going? I mean, you did a nice job of talking about it, but it always seems like you have a few that don't want to do it because we always did it this way. And this is one of the questions we get a lot is we understand there has to be education. How did you successfully get that done?
Yeah, I'll give my insight and then Dr. Heckenbuchner can expand on that. But I think having the conversation as like a roundtable discussion and hearing why people were concerned about it, but not just letting it rest. We had that initial conversation, but then we continue to have the conversation, and you have your early adapters and we share their data and we share their results, and then got the kind of later adapters to come on board and have some pushes when reminders of also, not just education, but forgetting. So serving as reminders too along the way.
And I completely echo that. And just to add some additional insight, there are multiple challenges, with educating. Certainly, if you think about just the surgical team, what we're up against, because we're dealing with surgeons, the attending surgeons who are in different settings and capacities. I, as an Emory surgeon, all of our work was certainly welcomed by all of the Emory faculty who are my partners and I work with all the time. And they were very happy and eager to have the work that Melissa and I have been leading. And so it was very easy to get my direct partners to, I think, jump on board with this initiative. However, we don't work as closely, as some of the other surgeons at EUHM. And so communication and not having a direct partnership there sometimes makes education and sort of rallying people around this a little bit harder. One of the other kind of, I would say, pain points and headaches is rotating surgical trainees and residents. And when you're dealing with a whole new team every month, that has its own challenges. And so Melissa and I put a significant amount of effort and time into creating a centralized resource guide. And it's a live document that's on a site called SharePoint that everyone has access to. And so you want to create centralized resources for teams and providers at institutions, so to support them, because it is hard to constantly remind people via text and email. And then it honestly has taken a lot of leadership and effort, both on my part and Melissa's part, to educate people. We have taken this on our shoulders and upon ourselves to make our patients more safe because we believe in this work. And that requires us showing up in a leadership capacity in multiple venues, at multiple meetings, where we present the same work the same way every time. We send people emails the same way monthly every time. And we have constantly communicated with our team, texted people, and had individual conversations around this so that people understand that when we're working on this, that, you know, this is how we gently remind people, but also lead people in an area where they may not have the time and energy to do it. So it does require leadership and persistence.
I think one more thing that came to mind too is just having champions in each area, you know, having that team picture that we put up in the beginning, you know, they also are our wings, right? They are out there seeing everything day to day. And so that's been very helpful, as well as using our champions to identify what the best way to educate their team is. So, you know, maybe on the unit, we found that huddles and individual interactions to get feedback worked best, but in pre-op holding, more of a group setting works just fine. So, you know, relying on them to tell us how their team functions best too.
Well, it was very impressive, and congratulations to both of you and your whole entire team for the wonderful work you have done. I would like to open it up. I know Cheryl has said you could put a question in the chat or unmute your phones. And are there any questions at all from any of the participants listening today? So I just want to remind everyone, while you're thinking of your questions, that GHA, we will be sending out our application for the next Patient Safety Award that we will be announcing in 2022. That will be coming out in June. So I want to encourage everyone to take the time to submit your award-winning projects, because we know that everyone is doing great work out there. So any questions at all? I want to just thank you again, Dr. Heckenbleichner and Melissa. You guys did a great job today. Very exciting to hear about all the wonderful work you are doing and the way you have processed it and showed it today. It was very, very knowledgeable, and I enjoyed it very, very much. So I want to just remind everyone that our next presentation will be on May 5th. It will be presented by the Shepherd Center, and they're going to talk about responding to the COVID-19 pandemic through the use of telemedicine. So I hope you guys can join us again on May 5th. And again, I want to thank you both. Emory University is well represented this year with all of our award winners, and congratulations to all of you for the great work that you continue to do with us and for us. So thank you very, very much.
Thank you, Kathy.
Thank you
Thanks
so
for the
much.
opportunity.
Absolutely.
Have a wonderful day.
You too. And thank you all for calling in today and listening. I hope you have a wonderful day. Take care and stay safe. Thank you.